Hi, I'm Paul Helen. I'm an anesthesiology resident at UCLA. Just wanted to make a quick video on a checklist for starting intern year off right. All right, I just want to cover three quick things. The first of which is to answer the question of do you need to remember everything from medical school? I want to go over a list of what I consider time sensitive skills. And lastly, go over a method for providing handoff. Just a quick thank you to Dr. John Bartholet. John and I were interns together on a few rotations, and he and I came up with this list together. So thanks, John. Okay, do you need to remember everything from medical school? No. But seriously, you don't need to remember everything from medical school. In reality, you only need to have extracted a few key skills. The first of which is can you obtain a careful history and physical? And from that history and physical, can you generate a problem list, uh, either by systems based, like they do in the ICU, or in order of priority? And can you generate a list of critical differentials, or also known as can't miss diagnoses, from common chief complaints, an example of which I'll provide on the next slide. If you can do these three things, you have obtained from medical school all the tools necessary to start off intern year. Let's talk about how to excel. Okay, here's an example of what is called critical differentials or can't miss diagnoses for chest pain and shortness of breath. This concept of critical differentials and can't miss diagnoses was introduced to me by a couple brilliant ER doctors that trained at UCLA Harbor when I rotated through the ER. When you think of things that might kill the patient, you can generate a list for common chief complaints like headache, back pain, stroke, upper GI, lower GI bleed. You want to think in terms of, for the patient that comes in with chest pain, while I'm working this patient up, what are some diagnoses that are going to cause maximal death or maximal harm in this patient? How do I recognize them so I can intervene upon them quickly? And that's where you come up with your list of critical differentials. So you can build off this list for these two chief complaints, but I would encourage you to think of common reasons that patients come to the hospital and to generate a list of things that can cause maximal morbidity and mortality as you build your list. Okay, eventually at 2 o'clock in the morning in your intern year, you're going to get a page that says, hey doc, this patient has shortness of breath or chest pain or is unresponsive or hypotensive. And from this, I generated a list of what I consider time sensitive skill sets, both diagnostic modalities and the potential for treatment that at 2 o'clock in the morning you're going to want a strong handle on your own. You're not going to want to call that cardiologist to help walk you through interpretation of an otherwise normal EKG, or call that radiologist and have you walk through the diagnosis of a tension pneumothorax that you should have been able to read on chest x-ray. So these are some skills that I feel you should have a basic interpretation of and a basic handle on. So at 2 o'clock in the morning, you can help triage what is urgent versus benign, or what is emergent, and how to intervene upon them. I'm not going to go over analysis of 12 lead EKGs or chest x-rays, but rather I'm going to point you in the direction of some resources that can help you develop these skills. Okay, it's my opinion that regardless of the type of physician that you are, whether you're a surgeon, a psychiatrist, an anesthesiologist, or an internist, every one of those doctors should have basic interpretation of 12 lead ECG skills. I listed what I use here. Now, this is just my system for interpreting EKGs, and it sort of doesn't really matter what system that you use so long as you have one that you can use every single time for every EKG until it becomes reflex for you that you can rely on when you get that page at 2 o'clock in the morning and you're super tired. I would suggest this book to the left by two ER doctors. It contains 212 lead EKGs with a simple one-liner. The way I use this book is that I made a Word document with this little box here, and I walked myself through a few EKGs a day until I was done with the book. I felt much more comfortable in ECG interpretation when I was done with that. I'll put the link to the Word document that I use if you're interested. Once again, though, it doesn't matter what system that you use so long as you have one and that you practice it. You don't want your first time looking at a 12 lead to be 2 o'clock in the morning when you haven't looked at one for several months. It's like riding a bike. It takes practice. The same is true for chest x-ray. On the right here is my interpretation, or I should say my system for interpretation of chest x-rays. I use the same thing every single time, and I would point you to this source over here which is a book you can buy on Amazon. It gives you 100 chest x-rays in a 2-page format. One page gives you the chest x-ray, another page gives you the interpretation in detail for the non-radiologist. Again, practice makes perfect. Here's an example case from that book just mentioned. Chest x-ray on the left, one-liner up top, detailed interpretation for the non-radiologist on the right-hand side. Excellent, excellent textbook. Okay, at some point, if you haven't taken it in medical school, you'll take ACLS, Advanced Cardiac Life Support, and Basic Life Support courses. It's really hard to think of anything more important to have just off the top of your head, mastered, studied well, than ACLS and BLS and the algorithms that are found within those courses, 2 examples of which are here. You don't want to be that provider who is fumbling through a pocket guide in the midst of a chaotic situation like a cardiac arrest. I've been in several hundred codes. I've seen great team leaders. I've seen not so great team leaders. I've seen smooth codes and absolute chaos. The difference seems to be the good team leaders have the basics of ACLS and BLS down cold, and they rely on these cards only as cognitive aids in the setting of extreme chaos. They aren't trying to study these algorithms for the first time since they took ACLS a year or 2 ago. You don't want to be that person. Spend some time with these and know them down cold. Okay, so that patient that was in cardiac arrest now has an endotracheal tube in place, and the respiratory therapist looks at you and says, okay, what vent settings do you want, doc? And from that experience, you want to have some basic ventilator settings. In addition, do some troubleshooting when the alarms start barking at you early in the morning in the ICU. One resource for figuring out those two for the non-intensivists is this book called The Ventilator Book, written by Dr. Owens. It's very brief. It's only about 100 pages. It gives you some tools for basic ventilator settings and troubleshooting. It's also a very good idea to make friends with your local respiratory therapists who can help guide you through basic ventilator settings, troubleshooting, and help you understand what type of ventilator that you use in your ICU. An extension of ventilator management is interpretation of ABGs, for which I don't have the best resource off the top, but understanding them, how to interpret them, and having a system for doing so is critical. Okay, in addition to the aforementioned time-sensitive skills, having an approach to hypotension, whether it's from that patient that just survived that code, who's now has soft blood pressure, you're getting paged about at 2 o'clock in the morning, or is that person who's peri-code with marked hypotension in need of resuscitation in the ER, having a system for approaching those patients is critical. This link here is a brilliant article that presents a systematic approach to hypotension utilizing these 4 variables: heart rate, volume status, cardiac performance, and SVR in a systematic format. It is exceptional. They go into detail about how you can use certain tools to assess each one of these components in order to help figure out why this patient is hypotensive and to have targeted treatment modalities addressing their particular etiology. All right, there's very few memories that are as embarrassing and painful as my first attempted handoff when I was giving a list of 10 patients and told to find the night person and hand off my patients. I, like the other interns in the room, did not have a clue about how to do that. I fumbled through it. I gave probably too much detail or not enough detail. The order was chaotic and I was nervous as can be. I think the reason for this is that a system for providing handoff is not taught or very intuitive in medical school. This picture here on the left is something that I developed initially, or I should say at some point during intern year when I got just tired of looking like an idiot. I kept this in my scrub pocket and I would pull this out for every handoff, put it right next to my patient list, and go through each one of these in order for each patient. Once I started implementing that, my handoffs were smooth. I was in and out, and I got compliments from the night float person that said, man, you really make this nice and easy for me. So I want to pass along that. This list here on the right is an extension of that. You want to talk about who the patient is. This is a 74-year-old guy. He's got congestive heart failure, admitted for diuresis. That's why they were originally here. They're still here because in the middle of that diuresis, we overshot, gave him an acute kidney injury, and then he aspirated. So we're treating him for pneumonia and an AKI now. He's clinically stable. You want to explicitly point out who is what is called a watcher or not, who's stable or not stable, what changes you made for each of your patient today, and the potential for pertinent exam findings. You don't have to read the physical exam for each one of your patients, but if you anticipate, that a nurse might page them for something that is unusual, it's worth pointing out to night float. Probably the most important two components of this list is the contingencies, which are you're anticipating what problems that each patient might have and explicitly making a recommendation in writing for their solutions. The night person, of course, is still going to exercise their own clinical judgment, but when they're carrying 100 patients, if you can make their life easier by saying this is the most likely thing you're going to get paged about and this is what we're using in our treatment plan to help fix that, it'll make their life so much smoother at nighttime. Lastly, the code status of each patient is obviously important. Okay, in conclusion, have fun, be safe, always ask for help if you need it. Intern year is anxiety provoking initially, but it rapidly becomes a time of extreme personal growth and confidence building as an early clinician. I want to remind you again that you don't need to remember everything from medical school as long as you have a grasp on some time sensitive skill sets and can generate those critical differentials. You do have time to look stuff up before you present a case. So it is not necessary to have all the facts immediately available in your head. So have fun in your time off between graduating medical school and starting intern year. Take care.